Hello, CAC2 colleagues. This is Joanne Salcido with CAC2 member organization, the Pediatric Brain Tumor Foundation. Thank you, everyone, for joining us virtually. We understand there could be many of you from 20 or so states and many organizations, so we appreciate having you here. A special call out to Amy Weinstein for helping me organize this webinar, and to Scott Gilman, who's behind the scenes right now making the webinar technology work. Understanding and enhancing the role of children with cancer and their parents in pediatric oncology drug development. That's the title of today's webinar, as everyone knows. 146, that's the number that comes up when I did a quick search on clinicaltrials.gov of phase 1 trials in the U.S. that are currently enrolling children with cancer. And is assuming enrollment is reached, there could be right now among those 146 trials, 8,000 children are participating. So our speaker's topic covers a very significant aspect of childhood cancer communities' experience and life, if you will. Before we get started, I'd like to remind everyone to please upload your September events, Childhood Cancer Awareness Month, onto the CAC2 MAP calendar, so we all know about each other's activities, and you can do that by going to cac2.org/events. Also echoing Vicki Binger, CAC2 President's announcement that we should plan to be in Washington, D.C., if at all possible, for mid-September's awareness activities. CureFest is the 15th and 16th. There's a Congressional Caucus Summit. There's a Golden Toast, which is on Thursday, right before CureFest. It's September 13th in the Library of Congress. So please mark your calendars and be there if at all possible. Finally, basic instructions for today's webinar. Your microphones are muted, as you must know. That's as a courtesy to everyone. Questions are deferred to the end of the session. We'll start with the ones, I don't think any were submitted ahead of time for this one, so please reserve and make sure to chime in at the end of Stacy's talk. And you can pose the questions by typing it in on the webinar dashboard that you'll see for questions. If technology is a problem, please send an email to webinar@cac2.org. And please note that we are recording the webinar today. We want to process it and then post it to the website as soon as possible so that you can view or review at your convenience. And finally, we value your feedback, so we'll be sending out a brief survey after today's presentation. Please let us know your comments. Next slide is our CAC2 values slide. I'm sorry, I didn't go over the agenda, but hopefully you had a chance to read those bullets. Please remember that we start every meeting with these reminder of our values, and at the top of the list is putting children and families first in everything we do. We do purposely are very supportive of each other's efforts. We take ownership of commitments we make within the collaborative. We're good stewards of our resources and action-oriented in our aim to give voice to the childhood cancer community. So it's now my pleasure to introduce our speaker, Stacy Crane. Stacy is a pre-doctoral fellow at Indiana University School of Nursing, and she will highlight what was learned from her dissertation about parent experiences when their child with cancer participated in a phase 1 clinical trial. She'll also touch on the implications for clinicians and researchers who work with children with cancer and their families, and finally on a way to improve experiences. Welcome, Stacy. Please take it away.
Thank you very much. First, I want to really just thank everyone for the invitation to present to you today. It's an exciting organization that you guys obviously are part of, and I'm really honored to be able to present the work that I've done here. And I'm going to describe, as was just said, a little bit about my predoctoral work, and now I'm in my postdoctoral phase. So I'll describe a little bit about what I'm working on now in collaboration with other pediatric cancer researchers across the country. So going to the next slide, I first need to acknowledge all of the funding sources for my predoctoral studies. I was very generously funded by a wide variety of sources, including the NRSA, the American Cancer Society, Oncology Nursing Society Foundation, the Midwest Nursing Research Society, and Alex's Lemonade Stand Foundation, as well as Indiana University School of Nursing. Then on the next slide, what I thought I'd start with is kind of just ensuring that everybody knows. I think many people are familiar with the various phases of clinical trials, but I didn't want to start off without at least, providing the context of phase 1 clinical trials. So as we develop drugs, they're first, of course, starting in the lab, and they begin typically in adults before they and move into clinical trials in adults before drugs typically move to clinical trials in children. So what phase 1 clinical trials are is they are the point where the drug has been determined to be interesting in animal models, has had some initial safety and efficacy testing, at least with adults. And at this point, what they're trying to do is figure out what the safe doses of the drugs are and get an initial idea of the side effects of the drugs and how they should be administered so they can move it on to further testing in phase 2 and phase 3 clinical trials. So these are very early trials in the clinical trial system. And it's not uncommon to, when we're running a phase 1 clinical trial with children, that it'll be the first time a child is being given a drug. A child with cancer is being given a drug to see whether it'll work. And that'll typically happen in the phase 1 clinical trial phase. So on the next slide, I just wanted to highlight, what kind of the crux of the issues are here. And essentially, there are ethical concerns with phase 1 clinical trials because the primary purpose is not intended to directly benefit participants. There is we've seen a movement recently. So there is now a secondary purpose during phase 1 clinical trials where we'll try to, start getting an idea of whether the drug will be efficacious for children with cancer. But really the primary purpose of these trials, as I said, is to determine the safe dose that the drug can be given at and to get an idea of the toxicities or side effects that children with cancer have with drugs. So on the next slide, on the next slide, what we see here is that parents, what we know from the literature is that parents primarily enroll children with cancer in phase 1 clinical trials based on hope of a cure and prolonging the child's life. And then on the next slide, what we know as well from the literature is that messages of hope are frequently shared by physicians during consent processes. And, certainly that's happening because everyone involved in this is very committed to trying to help the children with cancer. And when you have something novel like a phase 1 clinical trial that's interesting, there's reasons for hope to be involved. But unfortunately, as you see on the next slide, the literature also shows that the median life expectancy of children with cancer who are enrolled in a phase 1 clinical trial is 3.6 and 6.4 months. And the reason for that is that because these are such early trials, children with cancer are only eligible when their disease is no longer, or when there's no known curative therapy remaining for their cancer. So on the next slide, you'll get to the idea of, what I'm, interested in, or why my research was focused on. And that is to really understand these ethical concerns. We really need to understand what it's like to participate in one of these trials for the children and parents who enroll them. And on the next slide, what we see is that the literature currently, there's, at the time I did this study, I guess I should say, there was very minimal empirical evidence regarding how phase 1 clinical trials, what the experiences were like of children with cancer or their parents in the phase 1 clinical trials. There was a lot of really great work done on the consenting process, but beyond that, what it was like afterwards, there was very minimal research done. There was an expert hypothesis and expert opinions that the burdens of phase 1 clinical trial participation may include things like increased hospital visits, additional medical procedures, side effects or toxicities from the therapy, logistical problems such as transportation and parking, as well as financial costs. So there was a recognition of that likely there is burden, but nobody really had asked parents or children with cancer who had participated in the trials what it was like before. So on the next slide, you'll see the a description a little bit about my dissertation research study. And this was a descriptive empirical phenomenology study. So it was a qualitative study. And the idea was to identify the commonalities and meaning of the experience of phase 1 trial participation from the perspectives of parents of children with cancer. So phenomenology studies, the intention there is to enroll a small number of participants, but to capture a very broad depth of what their stories or what their experiences were like. So the interview that was conducted with this parent involved one primary open-ended question, and that was essentially to ask them what their story was and what it was like from them, you know, what their journey was like from the first time they heard of a phase 1 trial being mentioned, through to when the child started the therapy and enrolled in it, and through that process, through to the time when the child was taken off the study. So on the next slide, there's a little more details. What was involved in the study was there was a demographic form that parents completed, and that included everything from capturing whether parents traveled to a distant site, how far the site was, how far they had to travel to the phase 1 center, their relationship with the phase 1 center before and after the clinical trial, involved one primary qualitative interview. And then 7 to 10 days later, there was a follow-up call. And the intention of that follow-up call was to ask of any remaining questions. And then just to ensure, because many of the parents we spoke to were bereaved, that the experience of sharing their experiences hadn't caused any undue distress. And then lastly, some data was extracted from the clinical trial record. And that data included things like what was reported for each child to the phase 1 trial in terms of the side effects or toxicities and the outcomes of the therapy. So we accrued, or I accrued participants. Keep going back one slide, or keep staying back on the other slide. There was a sample of 11 parents, and they were recruited from 2 medical centers in the United States, as well as from childhood cancer support and advocacy groups. And that did include the CAC2, who assisted with recruitment in this study. So thank you very much as well for that. And what the study found is there were 5 themes that were identified. And I'm going to kind of go through each one of those themes. And here's the next slide here. The very first one is this idea of being the parent of a child with high-risk cancer. And a quote that supported that was, "This is my child here." And what this theme embodied was that parents were fully responsible for the child's well-being. And this sense they had that everything was really on their shoulders. It was, although they didn't describe it as a burden, it was something they had to carry. And this theme captured the need to be an expert in the child's cancer, to protect their child, and to prioritize their child's needs and desires. And there's a quote here, if you can hit the next slide, that describes a little bit about what one parent shared that we found in this theme. And that was, and this quote says, "I look at it kind of like the movie where the father and his son are in the concentration camps, and he's trying to shield his son from the horrors and trying to show him the beautiful aspects of life." So on the next slide is the next theme, and that one was related to the idea of this, parents' perceptions of their child's experiences. And that was that there is something that is about them that is very, very different. And what was captured in this theme is that parents perceive or see their children as special in 2 different ways. First, they see their child as medically complex. And secondly, they see their child as extremely brave and very resilient. So the quote, if you hit next there, that kind of highlights what was found under this theme, was this was a story that a parent shared of their child. And this child had gone over to a man who was just diagnosed with cancer, who she happened to run into. And she said, I want you to know you've got this. You can beat this. It's not as bad as what people say it is. He said, it's not. And she goes, no, you'll have your good days and you'll have your bad days, but you'll get through it. I promise. Another thing, you look good bald. So when you're bald, so when you're done, you might just stay bald. He started dying laughing and he said, well, you look good bald too. And she said, yeah, it just takes me a little while to get her baldness. So on the next slide, the theme there is contending with high-risk cancer, fighting this beast. And this theme really got at this pervasive struggle that parents are in to contend against the child's cancer and to not waste time with ineffective treatments. And this included assembling a team to help fight the child's cancer, and that included medical professionals, but even more than that, perhaps even more importantly in many ways, but family and close friends. And for some parents, that included reaching out to the parents of other children with cancer to form support groups. So what was interesting here is that the parents looked everywhere for treatments that might work. But even though they were interested in finding treatments, they had requirements for these treatments and what they would be willing to do based on the impact of the potential impact on the child's quality life. And underlying this challenge of fighting against the child's cancer was the struggle about trying to decide when it's time to stop looking for further treatments and focus on the quality of time left with their child. And that was really powerful and pervasive throughout parents' stories. They constantly questioned whether, whether it was time to stop. And the quote here, if you hit next, was a parent who said, you almost have a feeling of hopelessness. You just kind of wonder from day to day, well, is this the day we're going to have something that is going to work? Even though you feel defeated, you still have that glimmer of hope that there's something that's going to work. There's got to be something that starts shrinking it. So on the next slide is the theme that we found, which was directly related to participating in the phase 1 trial itself. And this theme really captured the elements that were specific to parents' experiences within the phase 1 trials. And what was interesting here is that parents understood that their child's life was at stake and that the phase 1 trials were unlikely to work. So they seemed to, though, even though there was a lot of hope in the trials and they were enrolling their child in these trials based on hope for finding a cure or at least of slowing down or stopping the cancer, they were they were able to still somehow be realistic in the hope. The appeal of the phase 1 trials for parents was that it was trying something different, something novel. And we did find that there were burdens associated with participating in trials, in particular the extra procedures, the research-only procedures that are part of being in one of these trials, and the extra lab draws. But parents managed those and children managed those by trying to incorporate enjoyable activities around visits to the hospital. For some parents, what was, sometimes concerning is that there became a focus on just trying to stay in the trial. One parent described how, for example, her child was having liver toxicities. And, when it came down to like the child was having mild pain, she would really question about giving the child even Tylenol or which drugs to give them because they were very concerned about exacerbating these underlying side effects in order to ensure that the child wasn't inadvertently removed early from the trial. The quote that I've kind of picked out for this theme here is that a parent who said nothing's ever given. Even in medicine that's been proven, we knew that. Everything was a ticking time bomb. We just knew that certain things would not work. It just seemed like the phase 1 trial was the one that offered the most hope. And I don't know if that was a tangible hope or not. So for the last seeing on the next slide, what was captured there was this idea of remembering and forgetting, that sometimes your brain kind of blocks things out. And while parents struggled to remember what had happened, because it was a retrospective study, and parents, their child may have been removed from the phase 1 trial up to 4 years prior to when I spoke to them. But it didn't seem to just reflect the normal difficulty of the passage of time. There seemed to be something more deliberate about this process, and perhaps even a subconscious choice about what to remember and what was remembered and what was forgotten. And the quote here speaks to that that I'd like to forget it completely. Again, the Ronald McDonald House, excuse me, the activities we did, the love of the cities, all were positive. The treatment itself, yeah, I'm not really interested in remembering a lot about that. So then on the next slide, what you kind of come up with when you finish a phenomenological study is an essential structure. What you're trying to get at is what the essence or the core of the experience is. And this is what was found in this study. And that was the idea of we don't have time to waste. So what seemed to pervade what parents' experiences were was a sense of running out of time to find an effective treatment and the need to use time well. And what was interesting is what using time well meant varied between parents and within each, child's journey as well. Sometimes it became a reason to go on a clinical trial, a phase 1 clinical trial, and sometimes it became a reason not to. Parents' experiences were not particularly focused on the child themselves. Instead, what they were really focused on was their role and responsibilities of a parent, their child contending to survive against this aggressive high-risk cancer. One second, I'm just going to take a drink. So important aspects of the phase 1 clinical trial experience included connecting with the healthcare providers, the choice to continue trying to treat the child's cancer in a phase 1 trial, and then as well being burdened by the phase 1 trial requirements. So in the next slide, I kind of have the key findings or takeaways from this study. And that was, interestingly enough, overall, parents' experiences in the phase 1 trials were positive. And that was interesting because it was regardless of what was involved or what the outcome of that experience was. Of the parents that we spoke to, we captured an interesting diversity in experiences. There was children with cancer who were on phase 1 clinical trials and had to be removed within a couple of weeks because their cancer was growing too quickly. There were children who were on multiple phase 1 clinical trials. There was a couple children who were long-term survivors after having been on a phase 1 clinical trial. There were children who died unexpectedly during the trials. There were children who had lots of toxicities and little toxicities. So what's interesting here is that overall, no matter what happened during the journey, parents still found that the experience was overall positive. Another key finding was that participants in these trials are burdened to varying extents by their participation. And some of that seemed to be related to what was required, because while there are certain aspects of trials that are similar, for example, some phase 1 clinical trials might require a lot more extra lab draws than others, and certainly the extent of those requirements directly affected the burden that families experienced. Communication between the child, parent, and healthcare providers really impacted the decision to go in the phase 1 clinical trials. And it was interesting because of the parents we spoke to, the children were included in all the treatment-making discussions, but in many ways, parents described how that made communication at times tricky with healthcare providers, because they wanted the child there and they felt it was important to have the child there. But then the language that the healthcare providers used would become couched, perhaps. And there was a lot of complex interpersonal interactions that seemed to be happening in terms of the parents wanting to protect the child a little bit, and then the children also, there seemed to be some element of the children wanting to protect the parents as well. So what also came through is that parents struggled during the on-study process to really understand the clinical trial system and define phase 1 clinical trials. And then lastly, what was key, or what really came through, was that symptom burden and symptom management is essential to parents' willingness and children's willingness to continue in phase 1 clinical trials. So from there, I'm going to kind of, there was a lot of really good, important data that was found in this study. And in terms of what I've done next, I've selected this last item for what I've kind of focused on, or one element that I'm focusing on, and that's the one I thought I'd share with you today. And that is the idea of how we're assessing symptoms and assessing toxicity in phase 1 clinical trials. Because the idea is that the better we are able to capture children's experiences during clinical trials, the better we as clinicians are going to be able to respond and understand and hopefully treat those symptoms. So it's important to assess symptoms or toxicities, which is the language clinicians use. It's important for enhancing each child's experience in clinical trials, and for identifying side effects for novel treatments that are being administered in the trials. So currently, how toxicities are assessed is that during medical appointments, children and parents report what's been happening. The clinicians document it in the medical chart, and then subsequently a research professional goes in and then assigns a grade for the severity of the toxicities. And the instrument that's used to do that grading is referred to the common terminology criteria for adverse events. We refer to it as the CTCAE. Unfortunately, it doesn't have a great acronym. What we know about this is that the toxicities captured using how we currently do it often do not accurately reflect children's actual experience of toxicity. So we've got some work to do here. And what we also really know is that self-report is considered the gold standard for assessing toxicity. So instead of having children report it and then the clinicians transcribe it and write it down, it would be better to find a way to have a patient-reported instrument, which would allow the children and their parents to directly report the toxicities themselves, and then without having that extra step in there. So on the next slide, I'm going to show you the common terminology criteria for adverse events. So this is how the toxicities get graded, and they're it gets specific for each symptom, but overall toxicities get graded between grade 1 and grade 5. In grade 1 are the asymptomatic or very mild symptoms where intervention is not indicated. Grade 2 is more moderate. It's starting to limit the activities, the child's daily activities. And some minimal or non-invasive intervention may be indicated. A grade 3 toxicity is severe or medically significant. It's disabling. Invasive intervention is indicated, and that might include hospitalization, IV fluids, or that type of treatment. Grade 4 is life-threatening in that urgent intervention is required. And then grade 5 is when a death occurs due to an adverse event or a toxicity. So on the next slide, just to explain this a little bit further, I've given the specifics, for example, of how nausea is graded using this system. So nausea, a grade 1 nausea would mean a loss of appetite without alteration in eating habits. A grade 2 is when oral intake is decreased without significant weight loss, dehydration, or malnutrition. Grade 3 is when the oral intake is inadequate, and then tube feeding or supplementation or TPN or hospitalization is required. So what we have this existing system, and it's used in every clinical trial across the United States in both adults and children. So it's important, the clinicians and researchers know how to use it. So what we want to do is find a way to, or what has been done is to find a way to create a patient-reported outcome version of this. And on the next slide, you'll see that the pediatric, some details about what's been created related to this. So First of all, this effort started with adults, and an adult version of the patient-reported outcome of the CTCAE has been developed and is currently in use. So there was an effort now, since we're using a patient-reported outcome version of the CTCAE in adults, to try to move it to children. And the work has been led by Dr. Pamela Hines and Dr. Bryce Reeves. And there is a National Cancer Institute funded a large-scale study to develop the pediatric version of this patient-reported outcome CTCAE. It's currently in the last stage of its development, and it involves pilot, and that involves not only developing the instrument, but they're currently at the stage of pilot testing it at 6 sites, Children's Oncology Group sites, to confirm its validity. And the idea behind it is that children, or what they found is that children 7 years of age and older can typically complete the instrument themselves, while parents can complete the instrument on behalf of younger children, and that's referred to as POXI report. To give you, on the next slide, gives you some of the wording or sample of the terms that are currently assessed by the, or of the toxicities that are able to be assessed by this newly developed instrument. There are 62 of them. You'll see that they are typically, that they are child-friendly terminology, and it extends to everything from, you know, you can see here, arms and legs feel weak, bigger belly than usual. Towards the end here, we've got wheezing, worried or nervous feelings. And it captures, the intent here is to try for every subjective toxicity to really get the child and or parent perspective on what's happening. To give a better sample of what this looks like, the next slide shows some of the questions that are involved. So what it tries to get at, what this tool tries to get at is the frequency that these toxicities are happening, the severity of the toxicities, whether they're interfering with quality of life, and then whether they exist or not. So the sample questions are provided here, and they include, for example, for headache, in the past 7 days, how often did your head hurt? And the response options are never, sometimes, most of the time, all the time. And then the severity is, you know, example of the severity question is, in the past 7 days, how bad was your sore throat? And the response options are, again, very similar. Did not have any, a little bad, bad, very bad. For interference, the questions go speak to, in the past 7 days, how much did your itchy skin keep you from doing things you usually do? And then the response options are not at all, some, a lot, a whole lot. And then for presence, a sample is, in the past 7 days, did you have any changes in your voice? And the response options are yes, no, I do not know. So the idea here is that the toxicities are assessed using maybe 1 or 2 of these questions based on what's most appropriate for that side effect. So on the next step, next slide, we'll describe a little bit about what the next steps are. So currently, the goal is to finish the pilot testing and to confirm the validity of the tool that doctors Pam Hines, Bryce Reeves, and the rest of their team have developed. And then it will be hopefully implemented into clinical trials and translated into other languages. And that process of implementing into clinical trials has started, will hopefully be starting very soon. There is one trial that should be using it. And the way that it's being implemented is that researchers pick which of the questions they wish to ask parents and children. So right now the attempt is not to ask, of course, all 62 questions to children or their parents, because we don't want to create undue burden. But there's 14 core symptoms that the idea is that every child with cancer or parent should be asked about, and those include things like nausea, vomiting, fatigue, pain, the most common side effects the most common and prevalent side effects. But then researchers can also pick specific ones that they ask about during the clinical trial. So then what the piece that I'm interested in looking at is to develop an interface that will hopefully allow this instrument to more broadly be implemented in the pediatric oncology clinics, so that instead of researchers having to pick in advance which questions they ask children with cancer and their parents, instead, there'll be an interface that will allow children with cancer and their parents to identify the side effects they wish to report or that are most concerning them. And that's the piece that I'm currently trying to work on. So my final slide that I have here, I really just want to thank you for your assistance, certainly for allowing me to tell you a little bit more of my work today, but also your assistance and willingness to support all of the research. It really does take a team effort to do these studies, and as you know, and I know I couldn't have completed my research study without your assistance recruiting. Thank you very much.
Thank you, Stacy. If we can advance, we have time for some questions. There may be a slide, I think, that we can have there. Thank you, everyone, for your participation. And if you have any questions, go to questions on your GoToWebinar, and I should be able to see if someone has one, and I can pose it for you for simplicity. I can get us started, though, with a question of my own. So, Stacy, you highlight very well the diversity and experiences between families and children, and in this population of mostly high-risk cancers. Children will have been a different part of that journey prior to enrolling. But do you have any discernment about differences between tumor types? Or was your sampling not long and large enough to discern that, and what your sense might be of that?
It's an interesting question, and certainly I think because there's certain different, each cancer is different. One might expect that the experiences of children with leukemia would be different, perhaps, than experiences of children with solid tumor. However, the reason why I didn't look at that was phase 1 clinical trials typically enroll children with a wide variety of cancers. They don't target any one cancer, and that is because they're looking at determining the safe dose and side effects of the treatment. And then the method that I chose was to identify the commonalities, or what was similar amongst their experiences. So I did not attempt to look at differences, but that is an interesting question that would be worth looking at in the future.
Stacy, this is
yeah.
Vicki.
Go ahead, Vicki.
Well, I just wanted to follow up Joanne's question, because this was on my mind. And first, I want to thank you for being here with us today. And second, I wonder, when you are noting these not anomalies, but when you notice the difference in this population in terms of phase 1 studies, it piqued my curiosity, not just about tumor type, and I know that Joanne would be interested in really kind of the devastation that children with brain tumors end up having, and what phase 1 trials means for them compared to solid tumors or leukemias. But I just wondered in general whether age is the determining factor here, because we do, our community, it interacts a lot with other rare diseases. Some are pediatric, some are not, and it feels to me like the phase 1 trials, when they are finally made available in rare populations, do seem like just such a relief that they exist, that there is an option for rare diseases. And I wondered if, just to follow on Joanne's question, whether if not seeing a difference between tumor type, do you feel like that age is the predominant kind of experience, because you have these units, these family units of parents and kids that are, and that, or is it just kind of the this is sort of outside the mainstream of drug development, so the rare population really would have these experiences, or possibly, I guess, in terms of Joanne's question, you know, would there be differences depending on how you were experiencing the disease, the tumor type?
It's interesting, and we did. I was fortunate to be able to speak to parents in this study that I conducted. The age of the children with cancer were from 3 years of age to 17 years of age. So I did speak to a broad range of differences. And what was, I mean, I think we did look a little bit at what the what the differences were for the younger children versus the older children and parents' experiences. Like I said, we were trying to look at commonalities, but it was a thought that we had. And the only thing we could find, and again, it was a very small sample, was that it seemed like the only time that parents talked about altruism as a reason for enrolling children in a phase 1 clinical trial is when is for children that were 11 years of age and older. The parents of the younger children didn't talk at all about altruism. And again, just to highlight in the method, the idea of the method was just to ask parents to share their story. So we didn't ask a lot of leading questions. The idea is to kind of figure out what parents say, but also note what they don't say, because what they're going to share, what's important to them is there. So it was interesting that only the parents of the older children spoke about altruism. It's hard to know what that means. There was also a sense that, you know, that altruism seemed to be important for parents whose child was deceased. They spoke more about the altruism during the interview. It is a good question, and I think likely there is a difference. Based on age. I mean, likely there is. There has to be something different about enrolling a 16-year-old child versus enrolling a 3-year-old child. Yeah.
Really good, Stacey. There's so much to dig into, and it's really the point. It humanizes these whole clinical trials when you have these kinds of conversations and investigations, because clinical trials is where, you know, the hardcore science meets the people, which is what the science is supposed to serve. So there's a lot that comes to the surface on these kinds of studies. You know, and even some phase 1 studies actually are very tumor specific because they're investigating a very, let's say, a targeted agent. So that would be interested to look to across the kinds of studies that the phase 1. So you're not short on follow-up work. But I have a question. When you were speaking about families filling this out, is this all paperwork? And are there movements to making this as an app or digitally in some way?
That's the piece that yes. So right now there is, right now researchers take it and they create their own survey based on which questions of the pediatric patient report outcome CTCAE they wish to ask. But yes, that's the piece I'm interested in looking at, is trying to create an app or a website that will allow us to, you know, implement it in a more general way without just including specific questions. And that's
so. Is there a vision to, at some point, when parents are in control a little bit more of reporting things without necessarily that prompt, like you're saying, they're just deciding what's important to them to report on? Will they eventually be able to do that just on their cell phone, on an app?
That would be the aim. It would be done outside a clinic visit so that they could report it. And that way, when during the clinic visit, have a reference to the clinician. But then if there was anything of new severity, either parents would be alerted to call the healthcare provider, or ideally, eventually an email will be sent to the healthcare providers, or some sort of contact be made with the healthcare providers saying that, oh, this child is experiencing a new severe symptom that probably, you know, would benefit from some follow-up. Yeah.
Got it. Okay. Any other questions? If you do, please unmute yourself. I'll give you a few seconds to speak up in case you haven't raise your hand digitally.
Joanne, this is Vicki again, and I don't want to swamp the questions, but while we're waiting for people to possibly reveal their questions, I was curious to understand how, Stacy, how your data and experiences have been received in various communities. I can imagine, that it's a relief for parents to hear about experiences that they might share. Have you had a chance to present in ways that either clinicians or investigators or folks involved in the trials have heard these findings, and have you gotten a reaction from them in terms of whether it matched what they were experiencing or what they were expecting?
It's interesting because actually, as part of the end of this study, I did send the results to clinicians at the centers where I recruited to ask them their thoughts, and they had a really, I'd say, really profound experience. It seemed like, because there was, within, I know with the one physician I shared it within a couple minutes, I got 5 emails from him in a row, and I had gotten 5 emails our entire life, talking about how it really spoke to him, how he really saw it, and how in what his experiences were working with kids, and how he wanted to figure out what we can do next to try to improve the experiences. So I think, I'm just in the process now of this article of these findings was just published, and I'm preparing an article for, I'm preparing a second article on it. So it's going to be interesting to see how the findings continue to be received. But so far, I really appreciate that clinicians seem to be, finding, agreeing or seeing. I guess it's hard to phrase it. Aligning with what was found, and feeling like this speaks to the fact of, we've got we can do even better. Yeah.
So, Joanne, are you
Wonderful.
there? Did you see Joe Baber's question that came through?
I think Joanne may be having some technical difficulties.
Well, I will.
Vicki,
my technical difficulty was the mute button. Sorry, guilty. Question from Joe. Thank you for turning that in. Is palliative care a factor in phase 1 clinical trials, or how does that interface? Yeah, how are those aligned or not?
It does, and definitely it was interesting to hear some of the parents describe how they, when they felt like they were transitioned to palliative care perhaps later, it seemed to be the message that parents received. So it's interesting to, there is a push to introduce palliative care sooner. And I think that the results of the study really reinforced the need that when you're enrolling a child in a phase 1 clinical trial, to also ensure that, that they also are speaking to palliative care services, and that support is also being provided at the same time. Because we are fortunate in pediatrics in particular that we are able to typically simultaneously offer those services.
Important question. Thank you. I think that's it. Now, remind everybody that you will be able to view this and share it with and watch it with someone else if interested. It'll be posted very shortly. You will, but before going on, I want to thank our presenter, Stacy. Thank you very much for taking the time and for your continued dedication to the topic. It really matters. So thank you for how you'll be able to influence the field in this conversation. Yes? People, please take a moment to complete the survey. It'll be in your inbox shortly. We'd greatly appreciate it. Your evaluation is very helpful for planning purposes. We will be working on scheduling our next webinar, so please be on the lookout for more information on the date and the topic. I want to kindly remind everyone to think about September equals CureFest weekend. So please make plans if at all possible. Lots of celebration and honoring going on then and the week prior. And again, thank you. Enjoy the rest of this week. Thank you. Bye-bye.